Live from New York. It's Benefits with Friends. I'm your host, Lou Bernardi, coming to you from a pretty cloudy day here in Woodbury, New York. We have a great show for you. Our first two-time returning guest on the show, Paul Joey Stone Jr., RHU. I'm going to bring Paul into the stream. There we go.
Hello, Mr. Lou. Or can it be Boo?
Yeah, Boo. Thank you. Yeah, I'm back to wearing my branded Boo shirt today.
It's the optimization officer. I love it.
I don't even know if half the time if people really know why I wear the silly Boo shirt. I was when I was at Health Rosetta, I was wearing the Boo shirt, and someone came up and said, "It's not Halloween." I was like, "Yeah, I should have probably thought of the acronym before I came up with the title." So
I love it though. Yeah.
For those of you that are out there that are new to the show, so the Boo is some silly nickname. It's Benefit Optimization Officer. I wanted to differentiate myself from other brokers and advisors and consultants because I think it's kind of the dawn of a new day for healthcare and health insurance, and that's my brand, and I'm sticking with. And by the way, my childhood nickname, and still my nickname with my identical twin brother, is Bubba, so it's not too far removed from that. So, Joey, let me let you introduce yourself to the audience today.
Yeah, absolutely. Thank you. Paul Joey Stone. I go by both names. It's a very short story. I won't go into that, but I'm currently the Regional Vice President of Sales for Apta Health. Was a consultant for 25, I hate to say it, it's really more like 30 years now. Ran a bunch of agencies, mainly in Virginia. And Apta happened to be one of my go-to solutions for folks who wanted to go self-funded for a lot of reasons, one of which was guided healthcare. And I've been there for just a little bit over a year now. So I knew them, they knew me, and it's been a great fit. So
yeah, no, that's great. And two-time guest, you were with a different company before. So today's conversation is centered around the concept of guided healthcare, which might be foreign for employers, plan sponsors, HR directors, benefit decision makers out there. A big part of the world that I'm in today, this Health Rosetta transparency world, is connected with me with people like you, which for the first 20, I hate to say this is my 32nd year in the industry, but the first 25 years I sold insurance.
Yes.
And that's what people are expecting. We've been kind of groomed as healthcare consumers or health insurance consumers to think health insurance is our only avenue to get access to health care, because it can be very intimidating. Obviously, it can be extremely expensive, especially if you're talking about hospitalizations and things. And then 6 years ago, I accidentally came across the true cost of health care, and my world got rattled because I went from feeling like I was the expert selling insurance to someone who was really just a pawn in this game of managed care that really takes advantage of the people that are out there delivering the healthcare, the clinicians. They were, by the way, Health Rosetta, I know you didn't get a chance to go this year, but they had about 600, maybe closer to 700 in-person attendees, and a real good percentage of them were doctors, clinicians, because there's a crisis in America. It's not a secret that the quality of our healthcare is lowest amongst most developed nations. And it's not because we don't have some of the greatest clinicians and doctors and nurses in the whole system. It's because they're forced to operate under this managed care system that really has forgotten about the patient and puts the patient last. They're a commodity to the healthcare system. They're a way to make money and suck money out of employers in premium dollars, right? So the higher the claims, the higher the premium. So now we'll talk about. Let me let you define guided healthcare, because I love the title, and I want you to explain in your mind what does that mean?
No, thank you. Guided healthcare actually is a term that Apta trademarked just recently. So we actually trademarked that. Really a lot of folks have called it care coordination, like care directed, whatever you want to call it, care coordination, navigation, whatever. Guided healthcare is a little, like, in my mind, different, because when guided healthcare is done right, it's a beautiful thing. And I'll get into like what makes it right in my opinion. But I think if I started with the story that where it didn't go the way it should have, I think it'll highlight, and it's a personal story, a very quick one, that'll highlight how guided healthcare is not supposed to be done, right? So in 2019, December, the middle of December, I went to my dermatologist because I had this brown dot on the top of my head that, I feared that it was melanoma. And they did a biopsy, and sure enough, it was melanoma. And he called me. It was really weird. It wasn't as scary as it should have been because I didn't realize how dangerous it was. I just, I thought, hey, whatever.
Yeah.
But anyway, he called me and he said, we did a biopsy. It is melanoma. You need to get this taken care of ASAP. Do not hesitate, whatever. So, he basically recommended a doc and so on. So I set up the appointment. I had the surgery on New Year's Eve day, 2019, right before 2020, because I didn't have this much work. But what's interesting is at the time, this is when I was running the agency, we had a level funded program with, I won't go into who the carriers were. It was a level funded program, and we had, quote, care coordination, right? Yeah. So had the doctor visit sometime mid-December, scheduled, and had surgery New Year's Eve day, 2019. Do you know when the care coordination nurse called me from that company to coordinate my care?
February 12th.
You're as close as anybody's ever guessed. It was sometime early February, right? And the woman was sweet, and I really appreciated the call. And I was like, I don't remember her name, unfortunately, but Betty, thank you for calling. I appreciate your concern. She was very, cordial and everything. But I said, the issue is like the staples are out of my head. The stitches in my chest where they took the skin graft are out and it's healing fine. I was lucky. I guess my doctor was really good and I didn't have any complications, but you can't help me at this point. I'm beyond the point of where you could have helped me understand what was going on, whether I had a high quality doc, all those different things. Right. Yeah. So, I looked at it and my company was charged $400 for that call.
For the call.
Yeah, it was a per case type thing. We don't typically work that way, but it was per case in this one. So I was like, what a waste of $400. I mean, for her to call and just kind of hold my hand and check in with me. Now, granted, if something had been going on, I had an infection or something, it would have been helpful, but that's not how guided healthcare should work.
No.
Right. So, the way guided healthcare should work in our model and the way we feel like it works best, it requires three things. And number one is some process or trigger that will alert a care coordination or guided healthcare team that a healthcare journey is about to begin, right? I mean, beyond a doctor visit. So if an MRI is scheduled or something like that as an example, that's when that trigger should happen, right?
Yep.
That care guidance should start at that point. Number two, it should not rely on the employee to be the only source of starting that engagement, right? Unfortunately, so many solutions out there, it's up to the employee or member to call in. Yeah. We know after an open enrollment meeting, about 5 minutes into an open enrollment, people don't do anything anyway. So that's number two. And speaking of practitioners and clinicians being at Health Rosetta, Mark Testa will love this. The third component of it is that the provider needs to be part of that conversation, right? We need to bring the provider into that care path, that the best choices and so on. So, that's really the goal is to lower the cost of care, improve the quality of care, and improve the member experience, right? And so when I say lower the cost, it's not necessarily that one it's the episode of care cost, because the doctor might be a little bit more, but they don't have any complications, very rarely or whatever. This one's lesser, but whatever. So it's the episode of care, lower quality, better experience, better. So that's how we define it. And again, there's a lot of folks out there that do it differently. That is not as effective, doesn't get the engagement.
You can hear me, right? Because I just changed my mic. I just want to
perfectly hear you.
Okay, good. All right, because I just had a little echo on this side. It's so funny because we just my first experience with care coordination, it was on an account that we recently, well, not so recently, about 3 years ago, moved away from one of the big three health insurance carriers. I hate to say names, but it rhymes with Metna, I'll just say. And I couldn't wait to call them and tell them that they had lost the case, because there was a series of events over the prior year or so where they said no when we knew that in this new world of benefit, not a new world of benefits, right? So what we're doing is not new. TPAs, independent TPAs, PBMs, it's not new.
Right.
But the data that's hit the market is relatively new to the mainstream population, right? There's some really advanced advisors that have been doing it for years, and I don't want to discount that. But for a benefit agent like myself, who was in 26 years of his career and had didn't realize a lot of the things that should have been happening behind the scenes, like care coordination, weren't happening. So when I called up Aetna to let them know we were moving this account, they were shocked. And one of the reasons I gave them is that this particular case had about 20. This is a relatively small group, about 175 members, about 130 employees. They had 20 people on their large claims report.
Wow.
20,
Yeah.
right? And so for you that are out there, the large claims report usually will be generated, and it'll include members that are within 50% of the specific stop loss amount. So in this case, it was $125,000 specific. So this was a report that included all of the members that had roughly $60,000 or more in claims. Not one of those people was in care coordination, because I pointed out a few of them, some of the more advanced ones. And what they said was, well, do you want us to reach out to them? And I said, oh, let's look at this. This is an 8/1 renewal, 8/1 of 2021 renewal. This member had his services June of the prior year, 13 months ago. What are you going to do for him now?
No.
Right? So care coordination is so super important. So I'll let you know what, I'm going to give you a scenario, and you tell me if this is how your company's guided healthcare is either different or more advanced than this. So typically what happens is, if you're still using an insurance carrier network, let's say an Aetna or a Cigna or a Blues or something like that, usually, even though you're just renting the network from them, they're not the payer or the TPA anymore. For some reason, they usually still like to control the pre-authorization process. Okay? So I'll use Cigna in this case, because this is who our newest experience have been on a lot of our cases, because we've moved a lot from that Metna company, and we can't use their network, right? So we're using
Cigna. That's not a word, right? Okay, just say I didn't.
And so we make sure that there's a data feed file that is taking all of the pre-certification notes, the medical records that are being generated through interactions, usually at the Cigna level in a lot of cases. And we're sharing that with our TPA, our pharmacy benefit manager, and the care coordination, like the population health, I'll call it nurse navigator support. All three of those entities are getting that data, right? And getting the data is one thing, but are they actually using it? So in this case, Engaged Health, who I love, so I don't mind plugging them if there's anybody out there who's looking for a population health company. They're fantastic. Nurse Sam, Nurse Angela get this data, and because they're nurses and they're the best people some of the best people in the world, and the most respected profession and most trusted profession, they're looking at this at a clinical level, and they're saying, okay, this is what the person's going through now, and this might be the start of a process where we know that if this test has just been recommended or pre-authorized, that the next step might be a start of a certain medication or a specialty drug or an injectable medication, or there might be a surgery or hospitals, something in that sequence, that step, therapy type of approach is going to happen. And they look at it and they want to talk to that person immediately, right? And they want to talk to that person immediately because they want to give support to that person, make sure that they understand what's happening. Because in the healthcare system, people usually are at the mercy of their doctors, and doctors are good people, but often tests are being done that are unnecessary.
Covering their butt, right? Yeah, right.
And they want to protect the member. They just want to make them informed healthcare consumers, better equipped to do it. And then a lot of times we'll get calls from the PBM and say, hey, same thing. Like, all right, this test is being done. It's very likely that the next step, because this is something the doctor has to check off, is this medication.
Mhm.
And the doctor is affiliated with this facility who has their own specialty distribution center, and you're
Mhm.
going to pay 300% or three times or 300%
Mhm. Right.
the street price for
Mhm.
this medication, right? So there's a lot of things, but none of that's important if it's not happening before.
Right. Exactly. Right. Absolutely.
You know,
Exactly the point. Right.
so take. I know your company, has a lot of advanced technology, right? And those is it called quantum?
Quantum health. Yeah. They're our partner. We have our own pod within Quantum, which,
Yeah. So tell me, so if you can enhance on what I said, like if there's more to it, specific to your company.
well, yeah, I mean, I think you hit on really a really important point, right? Like, and that is the person reaching out, the person that's initiating that call. 2 points. One has to happen before this journey really gets too far down the road because it becomes too late. They get engrossed in the system and so on. Number two, and this is what I think is really important, is you talked about that person creating you didn't say it this way, but creating a relationship with that member
Yeah.
to build trust, to show that I care about you, that I'm for you. We call them healthcare warriors. I'm your warrior. I'm going to hold you by the hand and go to fight with you, for lack of a better word, in this crazy, convoluted, complex world of healthcare. No transparency. You touched on it too. Doctors are great people for the most part, but a lot of times the employee or the members going to just take what they say at face value. They won't question them. They use terms they don't know and so on. So having this liaison, if you will, or this guided healthcare person that can help turn medical ease into English, right?
Yeah.
And vice versa, like to also communicate with the provider back to say, um, like, hey, my patient doesn't really understand their post-op or their post-discharge or whatever the case might be, to the provider. Like, we need to have a conversation, or you need to have another conversation, or whatever the case might be. So from that standpoint, just from a caring standpoint, yeah, absolutely. The way you described how it all works is very similar in that, one thing unique about the AptaPod is with different certain carriers and certain networks, some of the pre-certification, pre-authorization calls do actually come into the pod. They're not done by the network or TPA or whomever.
Okay.
Others, that pre-cert is done by them, but there's an immediate handoff, as you
Okay.
mentioned, whether it's nightly or whatever, to a care team. But the thing that I always say is, like, this interaction, we call it real-time intercept, by the way. It's a real-time intercept before things start to go, RTI. That's like a key that unlocks so many point solutions that are there to enhance the quality of care, to improve the cost of care, and again, to improve the member experience. So, but that key kind of unlocks that basket, because now we know, oh, they are going to have prescribed a particular drug. Now we can go out and get alternative funding potentially for that, or other ways to save money, or they're going to have probably this procedure, or they're going to be recommended surgery. You bring in, Mark's going to love me today, and you bring in somebody like Regenex.
Yeah.
And they have an option to surgery that might be a better solution for them. So the point being is that real-time intercept is the key.
Mm-hmm.
And getting that data to people before that journey gets too far down the road, like immediately, like in front. And again, we kind of use advanced imaging and above as that trigger.
Mm-hmm.
Not some 50,000 or 50% of the stop loss or anything like that. And
Right.
the truth is, you mentioned that you had 20 people. I guarantee you, none of those people were in any type of, well, maybe one person might have been in some type of care coordination or management program, and it was probably because it was super advanced, like a potential transplant or something like
Right.
that. Everybody else is just out there going through it all by themselves. Right?
One of the members was a $677,000 claimant with 9 chronic conditions and wasn't in case management.
That's insane. I
Can you
mean,
imagine? Can you
no,
imagine?
no.
One of the things that, one of the things that's really important to point out as that is essential to happen at this point, right before the care is, and it's not a new expression, but you know what they call the doctor that graduated last in its class? Doctor,
Exactly.
right? So any doctor,
Mhm.
well, not any doctor, but within your specialty, if you're legally allowed to do a certain procedure, and hopefully you've been trained to do that procedure, you can do it.
Right.
You, you know,
Right.
it doesn't matter as long as you hold your license, you can still do it.
Mhm.
So you go to the doctor, you go to your primary care doctor, let's say, or you go to a specialist and you have a test done, and they come back and say, like in your scenario, okay, well, we confirmed it through the test. You have this, and you need this procedure.
Mhm.
Where do you go? Right. So sometimes you just find a doctor on Google. Unfortunately, that's too often the case. Or your primary care doctor refers you, and maybe referring to a buddy.
Mhm.
But
Oh, yeah, absolutely.
what's the quality of that doctor?
Yeah.
Not how clean is their room, how nice is their office staff, how you didn't have to wait very long.
Right.
What's that doctor's success rate? How
Mhm.
many readmissions?
Right.
Do
How many do they
people?
do? Right.
Yeah, I mean, sometimes you only get one chance, right? We're talking about life and death, or limping the rest of your life, or walking without pain. There's two sides to this coin. So, at that point, care coordination can say, what hospital? Or we see that through the pre-certification, your doctor has admitting privileges at these 3 hospitals, right?
Yes.
And most
Right.
people probably know that, but maybe don't.
Mhm.
Which is the best hospital for that particular procedure, or what's the cost?
Mhm.
Now, sometimes that cost is really essential for the member, and sometimes it's not.
Right.
And sometimes the plan design will dictate what
Mhm.
happens. Sometimes people have tiered networks and all these things, but your doctor is planning on seeing you at this hospital. Okay, now what's the doctor's quality,
Mhm.
right?
Right.
How many of these procedures has this doctor actually done successfully? Have they done too many? And maybe everybody that walks into that doctor's office is a surgery about to happen.
Right, exactly.
Or does the doctor try to avoid surgery, like you mentioned, Mark? Is there an alternative that you can try prior to surgery or instead of surgery? Not everybody, they want to know their options. The whole point
Right.
is that we want to create an American healthcare consumer that understands that there are options, there's different quality, just like there's different, you have TVs, you've heard, right? You probably have a TV in your home,
Once. Yeah. One.
right?
Yeah. Yeah. Just one. Yep.
But just one TV. So, right? What brand do you just buy a TV? Or I mean, some people just buy a TV. Oh, it's $300, I'll just take it. You don't
Right.
care about the quality, right?
Mhm.
Other people are super, whatever the product is in the world, TV, car,
Mhm.
lunch, right? Not every salad is made the same. I know salad, it's half of it's here because I'm running behind today. But the point is that what could be more important than healthcare for the member to have the data, the information they need to make an informed decision that may or may not affect them or their loved ones for the rest of their life. That to me is the whole point of why this is so important, right?
Absolutely.
It's not to save money, it's to keep people healthy or get people healthy as soon as possible so they avoid future unnecessary health care.
Right.
At the core of it, I mean, you know, stop loss companies love that, right? They don't want, they would love it. And, by the way, if you're self-insured out there, and you have these types of mechanisms in place, you can lower your fixed costs like stop loss, because if they get it, if you're working with the right stop loss carrier that understands the capabilities of these advanced EPAs and PBMs and all these things, plan design is super important. And this is a component of the plan design. I know that when we shop for stop loss, with our partners in that area, the TPA, the PPM, and the medical management company, and sometimes even the data exchange, that changes the rate completely.
Oh, big time.
Oh,
Yeah.
they love that package that works effectively, efficiently, because they can say, well, we know when we work with this company, we just get the best results.
Yeah. To your point, I mean, so just kind of when on my personal situation, I was lucky enough at the time to be working for an agency, and I had access to quality data.
Mhm.
So when my doctor referred me to this particular doctor, I immediately, went in there. I'm not going to mention names of how I did it, and I saw like, and it was an outpatient surgery center. Everything was perfect. Like it was like everything worked out great. The chances are for that happening for most people is probably not there. Number two, I've seen this firsthand. So I've had consultants um, shop their stop loss and then send me the proposals to say, hi, I wanted to go to this carrier. This is what they put on the table. And we're shopping it to everyone else because we have a whole underwriting team, right? And we have data analytics that help us, to your point, negotiate better rates and so on. But anyway, so he sent it to me. I was like, hey, this is a pretty attractive quote. Does this particular underwriter know it's an Apta case, right? And he goes, I don't think so. I said, well, let them know, blah, blah, blah. And of course, it came back with some substantial discounts. Then all they did was ask the stack we were going to use, who's the PBM, who's the blah, blah, blah. And then once they did that, they applied the discounts. So yeah, I mean, it's hugely important. And you make a great point about, quality and, just navigating healthcare. We're in this business and it's intimidating to me. I mean, I negotiated a cash payment for an MRI on my foot about a year ago and paid it. I got my service. I paid it the day I was done. I still got billed by the insurance company because they sent it through. I have United. They sent it through them. So, like those type of, like most people wouldn't know what to do when that happens.
Right.
And we have many different models. So some of them we do have a cash pay option as an example, as a team of cash concierge, if you will, that will actually negotiate for you and work out that payment. So that real-time intercept on those models where we use that is big time. I mean, like on an MRI, an MRI could be $2,500 at this hospital, and a quarter of that in a freestanding imaging center.
Oh yeah, easily.
Yeah, most members don't know that, and we can negotiate cash on that. And the models where we use it, I want to be clear that not every model uses it. So.
Yeah, well, you know what? It's there's so many different things. Going out to Health Rosetta for the last 3 days to Chicago and listening to what some of the other benefit advisors throughout the country are doing is, what occurred to me is that, it's very regional. Some of the things that are really booming and doable in certain markets just aren't necessarily doable here in the New York market, or there's more pain involved with doing it. Or, so when I talk to the repricers about RBP, they're like, honestly, it's hard. It's hard there, right? Because we don't have any independent hospitals. Sloan Kettering's independent. Stony Brook Hospital is independent. I can't think of another hospital within 100 miles. You have the Northwell Healthcare System, the NYU Healthcare System, the Long Island, the Catholic Charities, the Long Island Health Network, it's called, Maimonides, Montefiore, all of these systems. And, it's difficult. It's not impossible. It's difficult. So, and I'll give an example, the case study that I mentioned to you. Well, by the way,
yes,
fresh off the press.
Brag.
All right. Or Hospital, Rosie Award winner, top 50 health plans in the country. We're thrilled.
It's not bragging if you can do it. So
yeah, and we're not doing. We didn't throw the kitchen sink at them, right?
Right.
They were running really poorly prior to our move. We're in our third year now. The first year they saved $1.4 million in claims. They had one high claimant and $677,000, 9 chronic conditions that I mentioned. We didn't change the benefits whatsoever. But once the nurse Sam got involved with this member and won his trust, and that was the first thing.
Yeah, absolutely.
When you talk about the guided healthcare, people aren't used to this. The big carriers aren't doing this in most cases. And if they are doing it, they're dotting I's and crossing T's. They're not doing it to the same extent.
Right.
We make it a point to reach out to the member. We usually ask HR, hey, can you please let Jane Doe, John Doe know that Engaged Health or whoever it might be, with Apta's care coordinator is going to be reaching out because they're skeptical. They think it's about saving money. They think it's about the cost.
Yeah, right.
And, he didn't want anything to do with it initially.
Right, yeah, no.
He thought he had it figured out. He didn't, but she won his trust because she just said, I'm here to help you. I'm helping. Any questions? They've had 72 interactions in the first 2 years. His
Wow.
claims happened to go down by $430,000 the first year.
Wow.
Wasn't our intention. We knew it would happen. But that's
Right.
not why we did it. It's because we were a lot of it was medication, injectable related, and there's just significant opportunity to save money because that's the disgusting side of the industry.
Not right. Were they J codes by chance?
Yeah, there were a bunch of J codes, and they're medical claims. A lot of times people think, and even at the conference, one of the questions that came up in our case study is, how does a company like OptiMed, which is a specialty sourcer and J code, interact with the pharmacy benefit manager? So, OptiMed for our plans is kind of unofficially exclusive to the medical side of the claim.
Yeah, exactly right.
Significant cost there, because if it's not being picked up at a retail pharmacy or mail order, it's a medical claim most of the times. Right? And they can work in the same sandbox, but sometimes there's some overlap between the PBM and a company that can source specialty medication. So that it's and by the way, Nurse Sam can help coordinate that, right? So she has the plan document. She knows what the different players can do. She gets them involved. It's no extra work for the plan sponsor. The plan sponsor hasn't had to do much of anything. It's not much work. It's not much more work for me as an advisor. And a lot of the advisors out there were kind of shocked to hear that.
No,
I still have more. I probably have more service-related work on our fully insured groups than I do on our self-insured groups. And it's only because we picked partners like Apta and other vendors that work together.
Right. Yeah. Right.
When with what you're doing there at Apta, what probably most HR leaders and CFOs that are involved in the benefit decisions don't understand about their insurance carrier, right? They're fully insured, or even if they're self-insured with one of the big insurance companies, is that there are 10, 20 different entities involved in that. It's not that insurance company.
Right. No. Right.
They've cherry-picked their partners to execute their plan, to generate the business outcome that they want. And unfortunately, that business outcome is Wall Street.
Oh, yeah. It's shareholders, right?
It's shareholders that they answer to. So when we take that plan and we deassemble it and then reassemble it and build a new embedded plan, it operates, it has the same purpose, but it just operates so much better if you're doing it right. It's like a car. We're fine-tuning that car, and we're getting as much RPMs out of that engine as possible. Like, and that's really it. And we're adding things like, we got blowers on there, we got the header on there. We're making just a visual for a car guy.
Nitro in there, right?
Yeah, it's they're not created equal. And that was kind of part of the presentation was very quick, so I went through a lot of slides very quickly when I was out there. But all self-insured health plans are not created equal. And what I love about what's happening in the market today is it is developing like technology should, because finally technology is such a big part of it that it is changing all the time. And that's not a reason not to get involved now. It means that the ability to make it closer to perfect as possible changes every year. So we're constantly growing and evaluating, and it's that data. Talk to me about data, because that's a big part, I'm sure, of what you're doing, right? So data drives the decisions, I would assume.
Absolutely. Definitely, it is a huge piece of it. But before I go there, you touched on, almost it's an easier lift, or burdens taken off of HR many times when we have this guided healthcare, because my clients were trained when I was a consultant, and we still talk about this. When an employee comes to you by phone and you're standing in your doorway, whatever, and they have a question about healthcare benefits, whatever, the first question you should ask them is, have you called the care coordination that we provide for you, right? They are experts. That's what they do. If they can't resolve it, then certainly I want to hear about it. But so HR can get rid of that burden. To that absolutely. So we have, and I don't want to make this a commercial about Apta, so that's not the intent.
Sure.
We have a sister company called Novo Connection that is an analytics platform that it's a proprietary plant program that we bought and then enhanced, right? The beautiful thing about it is on RxM Medical is it identifies, opportunities for the point solutions that we have in our stack, for lack of a better word. So if we have cash pay as an example, we can identify all the opportunities that cash pay could be utilized in that particular group. And then we can project out what that savings should be based on, right now we're averaging, let's just say about 140 in Medicare net, actually a little bit below that. So we can actually move that bar down to 140 in a particular area. And every area is different, as you mentioned. Some areas right, some are not. And then we can go, what if we get 40%, 50%, 60% engagement? What would that savings be? Of course, we can leverage that information, that data with stop loss carriers, but we can do it on pharmacy for alt funding, for moving people from higher cost to lower cost drugs that have the same efficacy. That's an interesting thing too. A lot of physicians, when we call the physician and say, hey, you get patient Jane Doe is on XYZ drug. Clinically, the clinical standard would be that they're on this drug, and the efficacy, here's the proof of efficacy through clinical trials, all that stuff. They should be moved to this lesser expensive drug. A lot of times the doctors don't know that. They don't know what the drug costs. They're like, I don't have time to do all that clinical work. This is my drug rep from Pfizer, and this is what they said to, whatever. And I know it's not that simple, but that's the point. A lot of times we're actually educating them, right?
Sure.
So the proprietary analytics platform on pharmacy and J-codes, another great example. We can identify all those opportunities as well. But then we take that, and then our care coordination team can use it, and then we use it for stop loss negotiations as well. So yeah, data analytics is huge, and to your point about improving, like constantly, like how we do it, how we just made some improvements, if you will, to a couple different models. Things change, right? And it's important to stay on top of it. And I think, again, not to make it a commercial about Apta, but when I was a consultant, that's what I love, because it's all vetted. It's all made to work synergistically. OptiMed's not going to step on our specialty drug, from the PBM side of things, provider, all integrated. It's all the kinks have been worked out. And, let's face it, there's going to be problems from time to time, but there's a team there to get it fixed for you as a consultant. I didn't have time to do that as a consultant. I need to be strategic for my client, right? Yeah. I need to be out there. I don't have time to go fix why OptiMed, got in front of a program that, another vendor is supposed to be in front. I don't have time for that. So that's one of the beauties of it. So to your point,
the flexibility is so important, right? And when for our partners, that's what we look at, right? Because we want plan control. Right. Meaning document, like the plan document. We want control of the plan document to whatever extent we can, based on the network potentially that we're using, right? So that can have some impact on it. But we want plan control and flexibility so that mid-year, if we need to, if we identify something, we have some companies that are written into the plan document that we hope never to use. A company like Specialty Care Management, I just saw Kimberly Langford. It's there, right? They know that they're hoping, right? They're just such good people. They're not hoping that people get, develop the need for dialysis. But that's what they're there to help us, and cancer and various things like that. But having that strategically placed in the plan document, there's a lot of them, right? So some of them we're going to use the actionable data to decide what's the next best thing to implement. Is there something that this particular population of this particular client would benefit from? Yes. For the health and wellness of the members, right? Because we don't want someone to have to sign 30 contracts electronically, right? It's just too much. It's too much if it's unnecessary. You mentioned doctors not knowing the prices, right? And that is absolutely true. I spoke to a lot of doctors over the last couple of days, in Chicago at the Health Rosetta conference, and the ones that are there that are attending this thing, and more each year, more and more attend, and even on the monthly webinars that we have, when they put us into breakout rooms, we can network over the not Zoom, it's I forget what the app is called right now, but it's doctors that are so curious about the things that Health Rosetta and advisors like me and Apta are doing. They want to know so much, they want to learn, and it's mostly independent doctors, because the independent doctors are fighting, literally, they are at war against the managed care system to preserve that profession. It is an uphill battle, but they're going to win it, because good prevails, I believe. And they see the prices. Dr. Gold, a direct primary care doctor, emailed me yesterday when I was at O'Hare Airport. And, Leon Wisniewski just released a new mobile app, shopping app called, it's Billy, but there's something before Billy. I forgot. You're going to kill me. But our webinar, live Zoom just went live 2 days ago, and it's a tool that takes all of the hospital data that was mandated under the ACA and a lot of the legislation that has come out of that, or developed from there, that is completely impossible for any individual employer or patient or member to use, because the data is so enormous. But he's been able to take the data from all of the hospitals, the cash prices, the average insurance company prices, the highest price, the lowest price, and put it into a map. There might be other things out there similar to it that maybe are doctor facility related. There's a lot of things happening out there. But for $10 a month, it can give a member access to a map, or an employer access to a map, or really anybody that can help them become a more informed consumer. And like you said, when you were talking about the MRI before, I need an MRI of whatever body part. I know you had some shoulder stuff, recently. I need an MRI of my shoulder. Now, there are definitely different qualities of MRIs, right? There's better machines than others. Maybe there's better technicians or radiologists than others that you want reading it. Whatever the case might be. But I think a lot of people would be surprised that here in New York, certain hospital that's about 10 miles from me, really well-known hospital, has a really great reputation, charges $7,000 for an MRI. They admitted, because they have to post what their cost for performing that MRI is $220.
Yeah, right.
CMS, Medicare, Medicaid, mandate that number. They're charging $7,000. Why? And why would an insurance carrier cover 50% of that? So they charge $7,000. It gets discounted to the insurance company's artificial discount price of $3,000. And now that member, who might be walking around with a $7,000 HSA deductible plan, is paying $3,000 for an MRI that they could have had for $400 next door to me. Literally, there's an independent radiologist here. Right? They don't know that. Well, they can know that today, but it's going to take time before that knowledge gets out to the average person out there. But there will be a day in the near future where people will have the information, and they'll partner with companies like Apta and other TPAs and solution providers that can make a really good living, making a fair price, rather than these gouging prices that have been able to develop because of just a lack of transparency.
It's insane. Yeah, and to your point, the guided healthcare folks that we have that data, right?
Yeah.
And they use it to help people, to guide them and to help them. But, it's also something in healthcare that's really unique. And a lot of people tie price to quality, right? And they think higher the price, the better the quality. Healthcare is exactly the opposite in many cases, where sometimes the best provider is much like video flashing.
It's flickering on the bottom. Yeah, but I hear you fine. You're good. Yeah.
Anyways, people associate high price with quality. Healthcare, many times it's exactly the opposite, where the lowest price provider is absolutely the best because they do more. They, amortize their cost over more surgeries, more procedures, whatever, on the machines that are so expensive and everything else, and they do it all the time. They have less complications, blah, blah, blah. the point is that people don't trust that sometimes. So the care coordination folks, the guided healthcare folks need to, they do need to build a lot of trust. That's a very important part of it. So.
At the conference, there was a lot of great sessions, a lot of great speakers. I took a lot of notes, but the founder of the Oklahoma City Surgery Center was there, and he was talking with another gentleman who I think founded the Free Market Medical Association, and theirs was a really powerful presentation because he did something very brave a while ago. I believe he was an anesthesiologist and independent, and he saw a real problem. Maybe it was with competing with the large hospitals, and they can perform procedures outpatient that don't have to be done at these hospitals that typically charge, 3 or maybe 2, 3, 4 times what his what a fair price would be. So he decided to post the prices. Right. So if you want to, if you're out there, and not for you, Paul, but if you want to check something out, if you want to check what I think hopefully the future of healthcare will look at, go to the Oklahoma City Surgery Center website. Just Google that, you'll find it, and you'll find probably a couple of hundred procedures. Price is there. You need,
right there.
You have a torn tendon in your ankle, you'll find it. You have something with your shoulder, you have an elbow, you have a knee, whatever the case may be. You need a gallbladder removed. Their price is there. It's a cash price. And so many people are taking advantage of that. He has people flying in from all over the world.
Right.
And interestingly enough, a lot from Canada, where, socialized medicine, I saw a report.
Yeah, right.
Well, the waiting list, people are fighting and think socialized medicine or national healthcare, whatever the case might be, is the answer. Well, the problem is when the government controls something and it's a price and it's a matter of collecting taxes for it, you don't have a free market. And then sometimes you have to siphon care, and you have to make rules and waiting lists and things of that nature. Or maybe you're too old to have this procedure, where here in the United States, unfortunately, if you have insurance, you're maybe more likely to get a unnecessary procedure. So that's something we really have to deal with. But, he has people coming in from Canada because they don't want to wait 6 months to have that lump removed, because that could be life or death, right? Sometimes it's a ticking time bomb, and you need to get that outside of your vehicle real quick. It's like a mob thing. I just got back from Chicago, so maybe I'm thinking like 1920s mob in Chicago.
I do think that we being the Health Rosetta minded, advisors and community and so on, I do think are making inroads to that whole thing. I think it's definitely happening. And to your point about quality of care and unnecessary versus necessary and all that, really that's what the guided healthcare is there to do. I mean, they help people facilitate second opinions all the time, because doctors, if you're a hammer, everything looks like a nail, right?
Yeah.
So for a lot of orthopedic surgeons, surgery looks like the right thing to do, and it's not really. I don't want to blame, not all. I'm just saying, but it's not their fault necessarily. It's just their world.
Yeah.
Right. And so sometimes Regenex or so, again, Mark, you can just send me the money. I'll take Venmo. I'll give you my Venmo. They might be the better solution for you, at least to try before you get the knife, So I don't know. I just think that's the beauty of, I put it this way, I've had economic buyers, CFOs, CEOs, HR directors, so on. When I explain the real-time intercept and the guided healthcare, they literally look at me in the eye and they go, why doesn't everyone do this? Like, why doesn't Medicare do this? For crying out loud, these people are in their 70s trying to navigate this convoluted, complex world of healthcare. And, it's not easy. I mean, it's pretty intense.
Healthcare and health insurance companies are the 2 largest lobbying groups in the country. They dwarf, gun owners, those companies. So here's some crazy stats, and this is courtesy of Health Rosetta. So the 4 largest health insurance carriers in the country had $11 billion in profit in the third quarter of 2022. Profit.
Right.
Where's that? The profit is coming from your premium dollars,
Mhm.
right? The third leading cause of death in the United States is preventable medical mistakes. There are 10,000 preventative serious medical complications each day. Not
Wow.
all of those lead to death, of course, but
Right.
preventable medical mistakes is the third leading cause of death. 28% of new cancer diagnoses are incorrect.
Mm.
So now let's talk about that for a second. So that doesn't mean necessarily that the person doesn't have cancer.
Yeah.
That could mean that the doctor diagnosed it as the wrong form of cancer,
Mhm.
and then it leads to treatment.
Mhm.
And that treatment can go a month, 2 months, 3 months. And I heard a story, Nurse Deb Alt.
Mhm.
I
Yep.
haven't worked with her yet, but she told a really powerful story. One of the conferences I went to in the last couple of years
Mhm.
about a patient um, who they took over as the population health nurse
Right.
navigation company, and that patient was either needed a procedure or new medication. I forget exactly what it was, and had been seeing this doctor for like a year for the type of cancer that they had. And in order to get this particular treatment, I don't know if it was a procedure, surgical procedure, or medication.
Mhm.
Um, the 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 American Medical Association requires pretty standardly that a certain test be done first.
Right. Is it a PGX test? A DNA PGX test?
Yeah, probably something like that,
Yeah.
right? And it
Yeah.
hadn't been done. And this
Right.
doctor's been treating cancer patients for 40 years. He was a little bit upset that he was being told what to do by this nurse from this really large population health company,
Mhm.
really well known. And he refused to do it. And
Hmm.
this went back and forth for a couple of weeks. Of course, the member was in the middle of this and
Sure.
wanted to blame alt medical management, but they stuck to their guns because they knew this is. And she basically told the doctor point blank, "Well, if you don't have this test, they're not getting this procedure." And it was a simple test.
Mhm.
Did the test, they expedited it. 2 days later, maybe one day later, whatever the case might be, it could have been an hour later. Came back the wrong form of cancer.
Oh, wow. Yeah.
They had wasted 6 months treating something, and the person hadn't gotten better. Should have been the first sign.
Right.
And he still was sticking to his guns, and it was the wrong form of cancer. They changed the diagnosis.
Mhm.
They changed the treatment plan. I don't remember exactly what the outcome was, but I'm hoping,
Well,
God willing, it wasn't too late, and that person finally started getting well.
absolutely. Yeah. No, I mean, we have that built into, almost it's an option for,
Yeah,
and almost everyone does it because you only pay it when you do the test. But people are either fast metabolizers or slow metabolizers of certain drugs, or DNA won't accept certain, so in this case, think, this person has cancer. What if they were getting an infusion or chemotherapy for 6 months that's not doing anything, you know, at risk their life? It probably wastes 60 to 100 or more thousands of dollars. And, like it's so much involved in it that you could know with a test in, like you said, days, hours, whatever the case might be.
it's
So
crazy.
it's crazy. It's such a simple thing to do too.
Yep. And
Yeah.
a couple of more facts here because they're just so disturbing,
Mhm.
right? Again, this isn't about our practitioners not having the best training and the best quality potential. But
Mhm.
if you're not living up to your potential, that's where teams fail, right? You can have a team full of all stars, but if they don't live up to their potential and they're all acting on their own, talking about pro sports, why does the NBA all stars that play in the Olympics not always win?
Mhm.
They're clearly the best talented team.
Mhm.
You
Right.
have to come together and work properly. But
Yeah.
60% of spine surgeries are unnecessary.
I think
60% of bypass surgeries are
real
unnecessary.
quick on the spine, did you hear that? I don't remember the exact numbers, but it was something like 80% of spine physicians said they would not have back
Would not
surgery.
have back surgery. No, they'll do them every day, but they wouldn't do it.
Yeah, right. Right.
There's alternatives. Mark Testa again would love love that quote. But it persists because there's such perverse, misaligned incentives financially.
Right. And they get
And
caught up in the system, right?
what you're doing there at Apta and what other companies are doing with population health and the data is something that insurance companies could do and could have been doing for the last 20 years. They have all the data.
Mhm.
There's no lack of availability of data. It's the lack of availability to people that really could use it
Mhm.
but they
Right.
know it,
Right.
you know.
Well, I
Uh,
think you're very familiar with the Validation Institute, right?
yes, yeah,
So, so we're validated. Quantum certainly validated. So, there's proof that you will receive a positive ROI from doing this, and that's where the data resides to make the best decisions.
yes,
So the problem is people sometimes don't believe that they're going to get a positive ROI, but the proof's out there. I think Quantum's been doing this for 20 years. They have over 18 years of validated
yeah,
results, right? And it's anyway. The point is exactly what you're saying. The information and data is out there. As consultants and as companies like Apta and others that do similar things, we need to keep telling the story. Which thank you for allowing me to do that today. So
yeah. No, this has been great. Is there anything we didn't get to that you wanted to share? Anything other than the New York Rangers being the absolute best hockey team in the league, which is obvious. I knew that was what was on your mind.
Yeah, well, it's funny. It was right here in my notes, but since you covered it, we're good. I don't see any need to cover it.
No, you know what? The more positive energy I have around the Rangers, the better. This is going to be our year again. So
Yeah,
certainly not going to be the Yankees or Mets year. So
I had a brief interaction with our marketing guy today on LinkedIn, and it's his birthday. So happy birthday, Joe! And he said, like, there's always hope. I'm a proverb like Cubs fan. It's like there's always next year, right? So
you know what, and talking about hope, there's hope for this industry. There's hope for health insurance. There's hope for healthcare. Health insurance is not healthcare. That was one of the really big topics, and it's worth drilling in to people out there. Is health insurance is a way of financing your healthcare risk. Everybody's risk. Yeah, right. Everybody has different risk. Every employer group has different risk. We talked a lot about self-insurance. Self-insurance isn't for every company, but it's probably for most companies over 100 if you're doing it right. If you have a way to eliminate as much of the hidden profits and artificial costs within that plan as possible, then it'll make sense. Unfortunately, we talk to a lot of companies that 5-10 years ago tried self-insurance with one of the insurance companies and they had a bad experience. Try to explain to them, you didn't do anything to address the biggest problem. You're paying too much for everything that your employees are consuming.
Right.
What we're talking about is just the reason why we need to work with independent TPAs is because they give you the flexibility to bring in these transparent contracts that are not only transparent in the cost of the services that you're using, but also the fees that they charge. There's no misaligned incentive where maybe, we make more when we save you so much more. Well, that could be a little bit of a misaligned incentive too, because now if the motive is only to save money, now you might start siphoning healthcare.
Right.
We don't want to do that either. So it's super important. But anyway, really thank you again for being on the show today. You've been a lovely, lovely witness. My cousin Vinny.
I do have one last thing, if you don't mind.
Sure.
So, whether you work with Apta or Lou or Boo or, anything, I think the point is, and I used to say this all the time, I still say it today. If your cost of insurance is based on your experience as a company, right? You're large enough to where your company's experience drive your cost, right? Why wouldn't you attack your claims as aggressively as you can without disrupting your members' experience, right? So, like, making sure your members are still having a great experience, but attack those claims with these type of programs you're talking about and that we use. And why wouldn't you do that? Like, this doesn't make sense to pay street rate when you could be paying a tremendous discount off a street rate.
Any other item on a company's balance sheet, any other item,
right?
Office equipment, computers, furniture, anything. If employers found out that they were overpaying by up to 100%, so paying twice as much,
maybe more, right?
Right, or more for all of the services, they would fire that vendor in a second,
right?
Because they understand it.
Right. It's a complexity that's
the biggest problem is, so this is complex, right? 30 years in, both of us, I say all the time, it took me 32 years to get 6 years experience, because for the first 25 years, I was selling what I saw, which was insurance. And I assumed that the insurance companies were doing their best to control costs. It made
Right.
sense from a business standpoint because we assumed that their profits were made based on helping the members make prudent decisions. But now, once that cover was pulled back and I saw behind the scenes and I understood the economics of health insurance and healthcare, most of the assumptions that we make as consumers of healthcare are wrong.
Mhm.
There's
No, I agree.
nobody that wants the cost to go down except for the employer and their members. And that's what, companies like you and people like you whose heart's in the right place, and this podcast is not about me getting business. It's about spreading the
Yeah.
word a little bit more, because the more people that are informed, they're going to look for solutions, and the consumer is the only one in this process that can change the way healthcare and health insurance, because when they start taking their business elsewhere, the market has to adjust to that. For
Right.
now, they got a customer that keeps coming back. It doesn't matter if the car's running or not.
Yeah, no, I agree. And we didn't even touch on fiduciary responsibility of employers and all that stuff. We could definitely go down that. But
Yeah.
you talk about 30 years in for both of us, but you still have a nice head of hair.
I'm
No,
trying.
I get it, man. I mean, what the heck?
Well, thanks again, man. Be
Thank
safe.
you.
I will talk to you soon. Absolutely.
Absolutely. Thank you, Lou. I appreciate
Thanks
it.
a lot. Take care, Paul.
Bye.